Hello, everyone, and welcome, and thank you for joining today's webinar on the care of patients with diabetes, the fourth in a five-part series. I'm Ralph Altieri, Chair of FIP Education and Dean at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences in the United States. It's my pleasure to be moderating today's webinar on competencies and workforce development strategies for diabetes-related roles. To note to all attendees that this webinar is being recorded and will be available on the FIP website, and certificates of attendance will be sent to all attendees. If I may go back one slide, please. So this webinar series also recognizes and honors the 100th anniversary of the discovery and the use of insulin to treat type 1 diabetes in 1921. We have come a long way from that historical turning point in treating what once was a very deadly disease of young people. And we've learned obviously a lot since that time, and now providing leading edge care today. This series is also part of a larger FIP focus on pharmacist roles in collaboration with other healthcare professionals in providing primary health care and caring for patients with non-communicable diseases, of which diabetes is one, all aligned with WHO and UN health goals. Today's focus is on education and training to develop a competent workforce capable of delivering the best care for individuals with diabetes. For those of us in education, we know it all begins with strong initial transformational education and followed up by continuous professional development training and upskilling throughout a professional career, because as we all know, advancements in understanding disease and therapeutics are being made every year. There are many facets to education involved in people-centered care for those with diabetes, from basic knowledge, of course, of the science of disease states and optimal therapies, but also interpersonal skills, evidence-based medicine, clinical and decision-making skills, pharmacotherapeutic treatments to manage the disease, as well as any comorbidities or other conditions, and then, of course, gaining real-world experience. Next slide, please. So today, we have three experts who will be presenting and then be available as panelists to answer your questions, receive comments. So they are Sally Ann Cavanaugh from the United Kingdom, Andrea Bruno Tome from Portugal, and Diana Isaacs from the United States. Next slide. So, as I mentioned, the webinar is being recorded and live streamed also via YouTube. In this recording will be made available, and here is the link to that. It's events.fip.org. When you have questions, please place them in the Q&A box, and we will be going through those. We're going to try to answer all questions after the three speakers finish, and so just notify in your question which speaker you are asking the question of, and we'll be monitoring that. You're welcome to provide feedback on this webinar and any others from FIP at webinars@fip.org. And if you're not a member of FIP, we encourage you to join us on this great journey that we're on for transforming education, workforce, and practice and science. So I mentioned earlier that it's people-centered care in treating those with diabetes, but this is one of the FIP development goals, number 15. And is all designed around people-centered care as a main domain of work for pharmacists. And you'll be hearing, obviously, more of that from our speakers today, but I will add one other development goal, and that is development goal number 20, which is on digital health. That's digital health in education, in practice, and in science. And I add that because today we will be hearing about the use of technologies in the care of individuals with diabetes from Dr. Isaacs. Next one, please. So as I mentioned, this is fourth in a series of 5 webinars on diabetes care. And all of this will culminate in FIP's practice transformation program on diabetes and a microsite on non-communicable diseases that will be launched 1 week from today on the 12th of November, just prior to World Diabetes Day on the 14th of November. So today's learning objectives: understand the strategies for developing a diabetes competent workforce. You can't provide care if you don't have a competent workforce. Learn from successful experiences on how to develop a competency framework for diabetes-related roles and relevant competencies that facilitate the delivery of diabetes-related services. Next slide, please. So here are our 3 speakers and the topics that they will be talking about. So if I may have the next slide, and I'll start with the introductions of our speakers. And this is our first speaker, Dr. Andrea Bruno Tome from Portugal. She is a senior expert strategist at McCann Health and she is headquartered in Portugal. She has a long career in competency development work, having developed the first FIP Global Competency Framework in her former life when she worked for FIP, which is where I first met and worked with her for a number of years. She has also been an academic at Monash University and now works with the premier health company, McCann Health. And she will be talking about version 2 of the Global Competency Framework, I believe. Correct, Andrea? So, title of her talk is How Can We Prepare and Equip the Pharmaceutical Workforce for Optimal Diabetes Care and Management? Welcome, Andrea.
Thank you. Thank you so much, Rolf. And thank you for FIP for this kind invitation to present in this series, fantastic series, which will culminate in something even greater for the workforce. I do have the fortune to have worked with Rolf and others that are in the call at FIP in my former life. And my expertise is really about competency development and frameworks. So I will leave the diabetes care and management in a sense to the experts that will follow me. And I will talk about more on how can we prepare and equip. So the first part, the why, the how, and the what in a sense. Next slide, please. So about me, and the caveat, I did saw that one of our panelists were talking a little bit about themselves in the background. So I did stole the idea, borrowed the idea from her. Do apologize, Diana. But this was really me in a nutshell. And this was a previous presentation that I did to students. And it's just looking at a different pathway within pharmacy. And all I wanted to highlight with this is that we can have different roles, different career pathways, and all of that we can and should be supported and have mentors that will help us along the way. This is a little bit of my background, and it started with associations and students associations that then evolved into working with FIP, doing the competency framework that Rolf just mentioned. And we've just launched the humanitarian competency framework as well a few weeks ago. So I do encourage you to have a look at those as well. I've worked with UK CPA in the past, RPS, the Portuguese National Society. I've worked with Monash in my previous job, and now I work with McCann. So a little bit of everything, been an academic, associativism, but all towards career development, practitioner development, professional development in a sense. That has been the core of all of these movings and changings around in my life. Next slide, please. So why we're doing this? Why is this important? And this has been a slide that I've presented several times, so I do apologize for the ones that have seen this before, but there is no health without a workforce, and there's no pharmaceutical health without a pharmaceutical workforce, in a sense. So the strategy for human resources for health from WHO actually states a vision for the workforce in 2030. And it clear mandates that there should be an optimization of the workforce. There should be support in the advancement of new roles and also in advancement of careers. Next slide, please. I did put all the references so you can have a look at it afterwards. So what is needed from the healthcare workforce? And this is no news to anyone in this call particularly, and especially during COVID. This is very trendy in that sense, that we need adaptability in a changing healthcare environment, especially in the past 2 years that we've transformed everything to more digital and digital events. And so it is a very much a work in progress on the adaptability, but also flexibility and mental flexibility as well is recognizing or recognition that enables development and seeking to be adaptable in the workforce. And that's what is requested from us in a sense. But also capability is to show what is the benefit of pharmacy to health. It's collaboration. It's looking at, and if we think about diabetes, the patient and the disease itself, it's not just us that can help the patient. It's us through a network of healthcare professionals that should and are supporting that patient. Because ultimately, that's the benefit that we would like. Better patient health outcomes. Next slide, please. But why? How can pharmacists actually optimize therapeutic outcomes and patient care? And really, what has been the drivers behind it? Because it has been all about policies, procedures, and resources. And if we think about, there has been some service redesign, but the focus should be workforce development. And how can we do that? How can we achieve individualized training and development? And that's through evaluation, feedback, and strategic planning. And that's what one of the things that we can say on how to equip and prepare the pharmaceutical workforce is, how can we do that? Through competencies. It's all about the development of competencies, which is the topic of this webinar. So next slide, please. So, and how can we do that? And this is the how. This is the most important bit in a sense. FIP has developed several competency frameworks, as mentioned previously, but also in a needs-based educational model. And what do we mean by that? It's looking at the local, the regional, the national, and international needs of the workforce, of the setting, of what you've been working with. And also considering, okay, to address those needs, what are the services that need to be provided in that particular setting that we've chosen, and what competencies are needed to address those services, and ultimately what education needs to be developed to make sure that we are able to do that. So it's all about a circle. It's all about continuation of education and development, and it had to be, or has to be, local determined, social accountable, globally connected, of course, and quality assured. On the right-hand side, you can see 3 of the documents. The Global Competency Framework version 1 that has been updated last year, and it actually includes digital literacy, which was something that Ralph also mentioned at the beginning. And it has been updated, so it's a living document. And these frameworks, as they're developmental, should work with us to continue to evolve according to the needs also of the profession. The last one is the Global Advanced Development Framework. That also was launched quite recently, and that's version 1. And that's to support the advanced part. Next slide, please. Conscious of time. So what do we mean by workforce transformation, and how can we help? And this is just an illustration of from the very foundation practice to the advanced and specialization, which means that pharmacists can have different career pathways, and you can specialize or stay in that broad aspect. And it talks about the stages of knowledge, skills, and experience with attitudes, also competency and performance, but it also gives us an idea of the broad or narrow focus. And diabetes can be one of the narrow focus on the advanced aspects of our profession. Next slide, please. And what do they look like? So this is just a snapshot of what we mean by foundation training or foundation developmental frameworks to advanced developmental frameworks. And this is really just to give you an idea. And all of these documents are publicly available in the FIP website, and I encourage you to have a look at them. Is on your left side corner, you can see one of the clusters, which is organization and management and competencies and behaviors. This also needs to be attached to tools to help and support the development of the practitioners. On the right-hand side is just another example of the advanced development framework. As you can see, it has pages. It's to help you to move on into your career and further into your pathway or into your setting, or in this case, specialization or having that special interest in diabetes and diabetes management. Next slide, please. So how can you use the advanced practice framework, for example? It's really to support the profession to progress and advance medicines related practice at all levels. It can be used by everyone, and it can be used at individual practitioner level as it can be used at national and regional level. The idea is to help to map and to plan the professional development and the careers development to make sure that you have that also portfolio aspect within the work that you're doing. It can be adopted and adapted in any sector, area, or field. Same thing with the global competency framework. So this complements the GBCF that we've just seen earlier, and it's a seamless transition between one and the other. It can increase opportunities for transnational collaboration and will enhance learning opportunities between countries. Overall, this is what it can be done, and it can be used as, again, as a guidance on career development. Next slide, please. But what's the added value for everyone, for the stakeholders? Why do we need this, and how can and should we prepare and equip the workforce? For practitioners, it's help them to develop their own career pathways and to understand where can they go and how to improve their own learning. For professional bodies, it provides support and tool for their members. For the regulators, it has that interest in patient safety, scope of practice, and measurement of competence. But also for civil society, or what we talk about for everyone, is about better training, better care, and better outcomes. And that's the added value of having that aspect of competency framework development and competency-based approaches. Next slide, please. It can't be alone. It shouldn't be alone. It should have a training attached to that. It shouldn't be used just as a standalone document. The idea is to develop a strategic plan, to develop tools behind the frameworks to support that developmental aspect of the workforce. So it's about that competency model to help that the self-assessment, also the observed assessment. So the 360 that we talk about also in peer assessment. It talks about feedback, receiving constructive feedback, identifying the learning needs through that process, and starting to build your portfolio. And this is a cost globally, I think, in all profession, is to think about the portfolio, what we are already doing and how can we improve. So it's really about that cycle of feedback and in practice regarding the setting that we're working on. And I did disclaimer this, I've borrowed this slide from Ian Combs in a previous webinar. So all of it is referenced, but the idea is to be able to do that, to be able to prepare the workforce, we also need to consider how we're going to use the frameworks, or how we're going to support the workforce into achieving a better health outcomes. Next slide, please. And this is pretty much similar to change management. And I'm finalizing now, really wanted to say is that change management is close to competency development, because it is a process. It is about creating that need, consolidating that need, and creating a vision together with the organization, with the settings, with the local communities or the local professional bodies. But also it's about communicating and empowering action. And how can we have those, what we call short-term wins? So how can we make sure that it's being developed and done and people are using it? And how can we improve that usage? And it's sticking to it. So all I wanted to say with this slide in particular is it's not done alone. It's not done in isolation. It requires a team. It requires everyone to buy into that aspect of the change and developmental change. Final slide, please. Thank you. So what are the key messages from all of this in a conscious of time? To prepare and equip the workforce for optimal diabetes care and management. That was my title. So what I can give you back is practitioners or pharmacists develop more quickly with a structured journey. That has been documented, and there's several articles about that. Competency-based performance evaluation and feedback do help and speed up that process development. Adapting or adopting the FIP developmental competency frameworks help, as this is not a blank page. We can use part of it to start to grow where we want and to start to help and support the workforce that we are looking at. But also you can have tools to assist the development of the workforce together with the frameworks. It's advancing practice and specialization can be guided by these frameworks. And a portfolio helps in the assistance of demonstrating what the practitioner's development have and the impact that they did. So overall, what we're trying to say with these slides is frameworks or developmental frameworks help practitioners do better and become better. Thank you everyone for listening.
Thank you, Andrea, for that excellent overview of FIP resources and how they can be used in upskilling our workforce to provide the best care that we can. And that was great introduction to this webinar and setting the stage for our next two speakers that'll move all of these things into the realm of diabetes care. So our next speaker, if I may have that slide, thank you, is Ms. Sally Ann Cavanaugh from the United Kingdom. She's a committee member of the UK Clinical Pharmacy Association Diabetes and Endocrinology Group, a senior lecturer in clinical pharmacy and practice at the University of Huddersfield in the UK, and practices as an advanced clinical pharmacist at the Sheffield Teaching Hospitals. She will present on designing a competency framework for diabetes-related roles, learnings from the United Kingdom. Welcome, Sally Ann.
Hello, thank you for having me on the session today. So I've been asked to come and talk to you very much about the process of designing a framework and how we've used it in the UK. And the reason I'm the invited speaker for this is because I was one of the group of people that developed it for us in the UK with a really specific focus on diabetes. Next slide, please. The reason I was a key part of developing this was I'm a member of the UK CPA diabetes group, and at the time I was co-chair with a colleague, Victoria Rizala, and we recognised that there was a workforce requirement to develop this competency framework. And this recognition of why we needed to do it came very much from our role within the UK CPA, but also us acting as clinical practitioners, us acting as pharmacists in the workforce, and realizing that we had a gap in how to evidence what we were doing, how to support our development, and where to go to next. So we recognized that if we were advanced practitioners in this field and we didn't have the clear path of where to go, that others would be in a similar position. And so that sort of set the seeds for where we were going to go. Next slide, please. So during the session today, what I hope to work with you on and what to talk to you about is obviously what Competency Framework is, but Andrea's covered that for us very much. So talk about the changing landscape of pharmacy and the profession clinically and practically, what we did to develop the framework and how we've supported that and disseminated it and what we've done with it really in practice. And then some of the reflections of what's gone well and what we'd like to do differently with it in the future. Next slide, please. So obviously, when we're thinking about a competency framework, when we're thinking about how do we demonstrate our competence in something, we are thinking about our knowledge and our skills and the attributes we have in order to undertake a given task, perform a certain role, claim the title that our job profession has or that we are acting in. And within that, within a competency framework, what we're very much talking about is that scaffolding or the structure in which to build all those knowledge, skills and attributes onto. And that's very much in general terms what we're talking about. Well, that's also what we wanted to do with our diabetes framework. Next slide, please. So when we were thinking as pharmacists, what do we want out of a framework, out of a competency framework? What do we need? Where do we begin? We obviously started with the thing of looking to see what was out there for pharmacists in particular and what competency frameworks existed and also what existed already for the diabetes workforce. And in that sort of scoping exercise, we were able to find really brilliant pieces of work around competency that had been developed and they were out there for the nurses, podiatrists, dietitians, but we couldn't find anything that met our need as a pharmacy profession. And we felt there was a really big need because we all know, don't we, the pharmacy role is changing so rapidly at the moment with a greater clinical focus. In the UK, we're getting much wider roles in GP practices, in community-facing roles, doing specialist roles and specialist clinics. I'm a hospital pharmacist, but within the time I've been in role, the scope of my practice has changed. I'm an active prescriber, I'm a clinical decision maker. So there was nothing to sort of map that for us as pharmacists. So we wanted to create something that would evidence what we were doing, support us, and provide a trajectory to support our future learning and our need. So we very much at this point recognised that there was some great work that existed for the other professionals, that we didn't need to start from scratch and that we could build something that was really valuable to the pharmacy workforce. Next slide, please. So then we needed to think as pharmacists, what is out there to support us as a profession? Now in the UK, we're very fortunate. We have the Royal Pharmaceutical Society, the RPS, who has lots of competency frameworks that are on the general scope of our practice and are about supporting us to develop at different stages of our career. So it's recognised the difference between what's needed as a foundation pharmacist or someone working at an advanced level or even the consultant level. So we were able to look at those competency frameworks and some of the professional curricula which are defining things in a slightly more detail. We were able to look at those and map the pharmacy career. We were able to look and say, if you're in the pharmacy profession, what does your career look like? What are the defined stages of that career? And what that meant was we'd be able to mirror the expectations for the pharmacist when they're working within diabetes. So whatever we set it up with the intention that whatever stage you are at your career and whatever stage you are in your diabetes professional journey, we would be able to map that to the other work you would be doing for your portfolio generation to justify and explain where you were professionally on that scope. So we did a lot of work then looking at what was clinically required, but also what was expected for the individual at their stage in their professional career. And that brought us to then, I guess, our working party of what our next steps were and what we wanted to create and what we could create. Next slide, please. So we wanted it to be meaningful. We weren't going to do this without it having a purpose at the end. and recognising the pharmacy workforce in the UK as being titled under post-registration and foundation, and then your core and advanced skills, and then consultant level. We looked at those frameworks and what was available. And we also looked that within those frameworks, there was very much what we would call pillars of practice. And we decided that our best way to support pharmacists at the moment was focusing on the clinical practice, to write a competency framework that very much defined what you needed to know at each level of practice from a clinical skills point of view, the patient-facing side of the role that they'd be undertaking. So we decided to focus essentially on domain 1 and domain 2, which would be called clinical practice, and that's the path that we decided to take at that stage. Next slide, please. So we are very fortunate in the UK CPA in that we have a very diverse committee. And we have people representing all sectors of the pharmacy profession. So we have hospital pharmacists, primary care, community pharmacist representation, educational pharmacists. So we have a really broad spectrum on the committee with a wealth of experience. And my co-chair at the time was the fabulous Victoria Rosala. And so she took the lead on this project, and I was obviously working with her on that. And we decided we were going to follow something very close to the nurses model in how to separate out the competency framework. So we defined the chapters and subsections. We worked as a committee, almost like a focus group scenario, to decide what did we need people to know about, what were people needing to focus on. And we defined what our chapters were going to be. So some example chapters were under general management, so screening, prevention, diagnosis, managing diabetes in hospital, pregnancy, etc. And then each of these chapters was given to an individual, essentially to author that chapter. So each person within the committee took on responsibility for a section or a chapter that was actually really relevant to their personal scope of practice, so that they could add that level of detail and clarity into there. So I have a special interest in diabetes in pregnancy, and so I obviously took that chapter. We did other work as well. And we did model it on the trend document because that's a well-established nursing document about the clinical aspects of care. So we did model it on that. Next slide, please. So once we knew what our clinical topics were going to be, and we had the defined areas for clinically, we then had to set about what could you be expected to know within that clinical field, within that scope of practice. And within that, we then split it out into what you would expect a foundation pharmacist to know. So what would we expect any pharmacist working in any sector of pharmacy at the early stage of their career to know? Or someone who's been working in a very broad and generalist role for a long time, but wouldn't consider themselves specialists in diabetes, what would we expect them to know? And so we defined what would be the foundation level of knowledge. And then for each of those sections and each thing, we built on that following the RPS model, and we had defined what you'd expect to know at advanced stage 2, at advanced stage 1, and at mastery level as well, which now would probably relate to something close to our consultant pharmacy level of work. And as I've said previously, we made a really active decision to focus at this time on the cluster 1, on the pillar 1, and about the clinical scope of practice. So what are the clinical things a pharmacist needs to be able to deliver to provide good core diabetes care? So that's what we set out, and we created what we refer to as our integrated career and competency framework for pharmacists. And the reason we call it a career and competency framework is because the way we've modelled it and the way we've set it out, it's not just defining what your competencies are. You can map and sign where your competency level is now, but it's also looking at what those next stages in your career could look like, and what would you need to do to meet that career expectation and that competency level expectation. So it's about enabling people as well to map where they may want to go, and to set up a sort of a personal plan, a personal development plan to meet their career goals. And that's one of the things that we really wanted to deliver through this work. Next slide, please. So assigning the detail, this was really difficult to do in practice, because what we really wanted to be able to do was match the level of experience and the person's scope of practice to a level of competency. And this is where the breadth of experience from the committee was really valuable, because then we were able to use a lot of what we would deem professional judgment about what can you realistically expect a person working at this grade to be able to do and deliver. So at this point, there was a lot of peer discussion and reaching out to colleagues working in different sectors about what they reasonably could be expected to do, what their current professional experience would be, and also from a protected within a role and job title and job descriptions, what's reasonable for a different level of competency as well. So we wanted to really protect the workforce. So understanding also was about what's taught at undergraduate level. What do all pharmacists come out knowing? What is that core foundation training that we have, and what can we be expected to know? And the other thing was about understanding what's commissioned. What are the expectations of the role, especially as the pharmacy profession was going through such big changes? We wanted to be able to know how to meet that core service need as well. Next slide, please. So this is what we came up with. This is actually cut directly from the framework that we created, and it's from the pregnancy chapter that we created. So what we have within our competency framework are these chapters and subsections which define how to support a person professionally. So for example, within the pregnancy, they apply very specifically to people working with pregnant women with diabetes. So it's not necessarily that we would expect non-specialists to know these. And we were able to break that down into the foundation, advanced, and advanced stage 2 level. And for example, so all pharmacists at foundation level, we would expect them to have an awareness of preconception care and what preconception care looks like for a person with diabetes. We wouldn't expect them to be able to act on that though. We'd expect them to be able to direct to services, direct to information, that sort of thing. And we also thought about they have ability to recognise hypoglycemia, because a woman who's hoping to become pregnant may be having much stricter and tighter control in their diabetes and therefore become higher risk of hypoglycemia. And we felt it was really important that all people, so all pharmacists were aware of something like that. And then we built on that with the different stages. Next slide, please. So these are the key things that, again, from the slide previously, we really sort of talked about what was expected to know at the different levels. Next slide, please. So we created our framework, but how was it going to be used? What was the purpose of it? How could it be used? How valuable was it going to be? So we had some vision of how we thought our framework would map to the professional workforce. And a core part of that was at the individual level. For the individual professional, how could it be used to support their career planning, review their performance, and support their professional development? I may have been a writer and author of this piece of work, but I personally use it to map my own career and to map my own competency against what we defined as a group, and to set my own professional plans and agenda. And it actually resulted in me going down a slightly different career path to meet my career gaps. So it's really useful from an individual and personal point of view. But we also wanted it to be able to guide employers in what they should expect of their workforce, because what we wanted to make sure was that people in similar roles in different organizations were being respected and supported in their roles equally, and financially rewarded at a similar level if you're doing a similar thing across different organizations. So we wanted employers to be able to use it as their foundation for job description writing, how to build a role, and what the expectations of that role should be. We've also used it from an educational point of view for developing educational programs. So I work at University of Huddersfield, and I use the Competency Framework to define the learning outcomes that I would expect of an undergraduate coming out to be a foundation pharmacist. But we use it also in our UK CPA training. We're all very connected with Diabetes UK and the educational programs for diabetes at other organisations around the UK. And we actually use the Competency Framework for defining learning outcomes and to build modules and learning programs that are valuable to the workforce and pitch them at the appropriate level for that pharmacist. So it's been a really important part of that, especially as the profession's changed over recent years. And we've also used it with commissioners as well to help design services. So when there's a local need or a local gap in service and they're wanting to use a pharmacist to meet the need of the population, to be able to define what need they're trying to meet, but what level of pharmacist they need to support that need, and how do we ensure competence at that level. So there's lots of different ways we've been able to use the framework. This is our vision, but this is also how we've actively used it as well. Next slide, please. And the only reason we've been able to use it so well and use it so effectively with commissioners, with educational programs, is that we, at the time of writing it, but also once it was published and written, having a really sort of strong network of people behind us to use this. So once we had written it as a group, we did actually take it to a copy editor and publishing company to get it professional, to make sure it's safe, to make sure it's usable in the workforce. And we also got lots of professional organisations to review and endorse our work. So UKCPA was an easy one because we were the committee for them. But we also went to the Diabetes UK charity to get their backing for it. And they're one of our biggest backers of this framework now. And they do hold it on their website for sharing wider dissemination. We had the Primary Care Diabetes Society back us, Trend, even though we used those their original model, they supported us. And the Royal Pharmaceutical Society gave us a letter of support as well, that this is a useful resource for competency development of pharmacists in diabetes. We did do books, so we did have hard copy books that we could hand out at conferences and events, but we also created the online versions as well that could be accessed via various resources. We did a launch event at one of our conferences. So we really sort of, where there were lots of people interested in diabetes, we launched as an official big event so that people were aware that we could support them and that they could support themselves in their professional journey. And we obviously did social media campaigns around that as well. Next slide, please. And it did work and it was brilliant. And it's been a really valuable piece of work to be part of. But we'd be remiss if we didn't seek feedback and didn't try and find out how we could improve on the work that we'd done originally. So we have sought feedback, and the general feedback is that people find it really helpful to match alongside their RPS portfolio, especially as we move towards a credentialing model. It's been used lots for defining new diabetes roles. And as someone who really advocates for the role of pharmacists in diabetes care, and is always pushing that every hospital needs a diabetes pharmacist and every CCG needs someone with that focus and with that role, it's been really great to hear that the Competency Framework has been key in modelling those jobs and being able to develop those roles. Again, using lots of educational resources as well. But we have now decided to go a little bit further in how we're going to use it in the future and use it more in a credentialing models capacity, and therefore map more closer to the RPS. Next slide, please. So as we move further forward with our framework, we're not just going to be focusing on that pillar one, not just on the clinical competence, but also what does the leadership element look like? How does education and research fit in that? And the idea with this is that our diabetes pharmacist professionals are going to be able to have a portfolio that is truly representative of what they offer the diabetes community from the clinical and the leadership and the research point of view. So sort of being a much more holistic portfolio, holistic competency framework moving forward. Next slide, please. And this is essentially the blocks and titles that we're going to be working with. So as we move forward with our new framework, we are separating out into the clinical practice, the leadership and education, but we still want to retain that real important step of it being important at the stage of your professional career that you're at now. And we have actually made a decision to remove the consultant element from our framework. So although the consultant pharmacists are very exciting and they are a really valuable thing for the workforce, we wanted to make this a document that was attainable to the majority workforce and be valuable now. And what we do know is that the consultant pathway's got very specific requirements and much more detailed faculty stuff exists already. So there was that need no longer needed to be met. So we focused it down. Next slide, please. And this is an example when we're just talking about what that practice looks like now. And I've provided in there that in the prevention strategy, you can have expert clinical practice about how you'd communicate with patients and what education could look like in that. So for example, a foundation pharmacist, the education element would be very much about signposting people with diabetes to appropriate resources, for example, lifestyle management. Whereas someone who's at advanced level, advanced stage 1 or 2, we'd be expecting that person not to just be doing signposting, but to be putting some education provision in themselves and supporting someone living with diabetes. Next slide, please. So that is my very whistle-stop tour of what we did as a professional group, what our goals were and our motivations for using a framework strategy, competency framework strategy. So I hope you found that useful. Thank you for listening during this time, and I'll be round at the end to answer any questions. Take care.
Well, Sally Ann, thank you so much for that really excellent presentation on what is essentially a roadmap for the practical development and use of a competency framework in diabetes care. And we look forward to your next steps in expanding that framework and how it could help all of us in designing something similar in our corner of the world. So our next speaker is Dr. Diana Isaacs from the United States. She is an endocrine clinical pharmacy specialist, CGM and remote monitoring program monitor, and co-director of the Center for Excellence for Endocrine Disorders in Pregnancy at the Cleveland Clinic Endocrinology and Metabolism Institute in the United States. She's a certified diabetes care and education specialist and holds board certifications in pharmacotherapy, ambulatory care, advanced diabetes management. And she serves in leadership roles for a number of pharmacy and diabetes organizations and is passionate about the use of technology to help people with diabetes. Her work in diabetes care was recognized when she was awarded the 2020 Diabetes Care and Education Specialist of the Year from the Association of Diabetes Care and Education Specialists. So we welcome Diana for her talk on diabetes educator roles and advanced practice pharmacists, upskilling for success. Welcome, Diana.
Great. Well, thank you so much for having me. It really is such an honor to be here today. And yeah, I'm basically going to describe kind of the advanced practice pharmacist, diabetes educator roles. And I'm going to share a lot about my experience because I work almost exclusively in 100% in direct patient care. So next slide. So I just wanted to provide a little bit of background about myself, just so you could see kind of what my education and training was in terms of what I'm doing now. So yes, I'm considered an endocrine clinical pharmacy specialist. I spend almost all of my time in diabetes. I dabble in a little bit of weight management, but usually it's also in people with diabetes. And I coordinate our continuous glucose monitoring and remote monitoring programs. So I do a lot with technology. And in terms of kind of what my educational background was, so I got my PharmD, and then I went on to do a residency. It was a 1-year residency, although now many people in my position in the United States would do 2 years. But it had an emphasis in ambulatory care, which is like outpatient management. And then I went on to get board certifications in pharmacotherapy, diabetes, and specifically ambulatory care, as well as the credential, which used to be called Certified Diabetes Educator, but now is called the Certified Diabetes Care and Education Specialist from the name change a little over a year ago. Next slide. So in terms of the things, what does an advanced practice pharmacist role look like? There's so many things that could be included. I kind of included things that I do because that's what I'm super familiar with, right? But I have in-person and virtual visits for medication management, which generally includes medication adjustment, titration, starting new drugs, stopping drugs. And I focus on type 1 and type 2 diabetes. I actually do a lot with a post-kidney transplant. Those are really fun patients to work with because they're generally on these high-dose steroid tapers. And there's a lot to do with the insulin adjustment during that time period. Weight management, I think, are great opportunities, especially when people lose weight, We need to think about de-prescribing medications and keeping people safe and preventing hypoglycemia. So there's a great role for that. And then we've just heard about diabetes in pregnancy, which is also one of my passions. And I think a lot we can do to help manage those patients with the insulin adjustments and lifestyle modifications. Now with virtual care and technology, it's a lot easier to provide this type of care virtually, and being able to remotely access people's glucose data to provide these kind of visits. And then also, we can't forget about the rest of the team. We should not, as pharmacists, be working alone, right? And that's where things like diabetes classes, shared medical appointments, where you can work with the endocrinologist or the primary care provider, the dietitian, the nurse, and really work together. And then of course, training, teaching the next generation. And we do a lot of hands-on training where pharmacy students or pharmacy residents are in the clinic and learning directly from me or the similar people like me working in my role. Next slide. So in thinking about the scope of practice, we're fortunate that we have collaborative practice agreements in most of the states in the United States to varying levels. And when these agreements are signed, either they can be signed by, one physician, or like in my case, it's signed by the practice, by the whole healthcare system, meaning you can work with many different providers, not just one. But it allows us then to be able to do the things like prescribe new medications or new technologies, being able to adjust them without, having to get approval every single time. Once someone is, referred to me, I can make those changes and I don't have to get it okayed before I go ahead and do it. Of course, we're still going to be counseling on those medications, and we want to, be performing medication reconciliation, checking for drug interactions, and all of those kind of things too. Additional things are considering referrals, like when should someone go and see a podiatrist or maybe a psychologist or a dietitian, and being able to directly make those referrals. In terms of physical exams, I would say this is an area that's growing, although pharmacists definitely are not performing physical exams to the same extent as other professions. It's common that we might do foot exams, we may check blood pressure and other types of things. And then of course, we're communicating this with the rest of the healthcare team, either in person or very commonly through the electronic medical record. One thing that you don't see on here is diagnosing, and that is something that is not done by pharmacists, at least not in the United States. But once someone has that diagnosis, then we are participating in that management. Next slide. So I wanted to just share with you a little bit of what the workflow looks like, because, in the outpatient setting, basically patients are referred to the pharmacist for disease state management. And there's actually many conditions that can be managed by the pharmacist. It is very common that many pharmacists participate in diabetes management just because over 10% of our population has diabetes, and it's something that our primary care providers really need help with. They have very limited time to spend with patients, and we know diabetes can be more complex and really requires a lot of follow-up and a lot of interventions, and that's where we can really be very, very helpful. So typically, patients would be referred, and it's very common that we might target patients that are a little bit more difficult, such as having A1Cs over 9% or are really struggling with hypoglycemia. And so they get referred to the pharmacist, they set up an appointment. And generally in this visit, the pharmacist is going to interview them, really get that full history. Usually, we have access to the electronic records, so we can make sure we look ahead of time and learn as much as we can know. But here, through that discussion with the person, we can go ahead and start, stop, adjust medications, recommend lifestyle changes, and make any needed referrals. And then we have that ongoing communication, which it's common, just with, I guess, primary care provider visits, their patients are seen every 3 to 6 months. But with pharmacists, they can be seen a lot more frequently. And so we can get patients to goal. We can continue to titrate the medications as needed. And then the hope is then, and what usually happens is that after a certain amount of time, patient gets to goal, their A1C, maybe that's coming below 7%, or with continuous glucose monitor data that they're spending, at least 70% in range is what we say. And through this process, hopefully everyone's happy, right? Because the patient's met the goal, the provider's happy, pharmacist is happy, everyone's happy. So next slide. So I wanted to pivot for a second and share with you. So when I joined my current role at the Cleveland Clinic Diabetes Center, it was about 5.5 years ago. And prior to me joining, they did not have a pharmacist in this specific role. They knew kind of what pharmacists can do, and they were excited about it, but they didn't know exactly what I should do. And so I tried to do a lot of listening and observing and trying to see where could I be the most useful. And I kind of thought about these three broad categories of, I want to improve outcomes for people, right? Improving A1Cs, reducing hypoglycemia, preventing hospitalizations, all of those things, right? But also the revenue piece is important too, that ideally, if I can do those things and bring in revenue or be reimbursed for my services, and that would provide very good value. So next slide. So with that, as I was doing all of this observing, next slide. So as I was doing all of this observing, I quickly came to realize that technology is where it is at, right? Technology is booming with insulin pumps and continuous glucose monitors and mobile apps. It is the thing that's booming. And there was this nice systematic review by Deb Greenwood and colleagues that showed that really optimal technology-enabled self-management requires two-way communication. Meaning we can't just throw a device at someone and expect, oh, you're going to have great outcomes. It involves that interaction with the healthcare team to understand the data, educate, and that's where there's improved outcomes. And so kind of a light bulb went off that that's a real opportunity there. Next slide. So I had the great honor of being part of this writing group about technology integration, the role of the diabetes care and education specialist in practice. And we really reviewed the literature, and we saw, technology's improved with patient outcomes, but it's really enhanced when the person is knowledgeable and actively engaged. And that simply wearing a device will not automatically translate into improved outcomes. And what we kind of came to realize was that, every practice really needs a technology champion, someone that likes working with technology, that's willing to stay up to date on the new advances and can educate the rest of the team. And that can really reduce therapeutic inertia and improve health outcomes. So who is going to be that technology champion? Well, I would argue that the pharmacist, the diabetes pharmacist, is really that perfect person. Next slide. So with that kind of all in mind, thinking about my role and everything and about providing value, I came up with these three programs where I feel like I was able to make a big impact. And so one of them is the CGM program, insulin pump training and virtual visits. And there's more things I do beyond this, but these were ways that I could contribute, kind of be the technology champion for my practice, and also bring in some revenue in the process as well. Next slide. And this is a quote from the American Diabetes Association Standards of Care. And it says, when prescribing CGM devices, robust diabetes education, training, and support are required for optimal CGM device implementation and ongoing use. And I think that's really important because nothing is set it and forget it. And what an opportunity here that we can provide this education and really enhance use. Next slide. So with that, we developed, actually, and it wasn't just me, it was with my team, but we developed a program with CGM. And just in case you're not familiar, CGM really is an incredible tool that goes way beyond typical blood glucose monitoring, which is just one point in time. And this provides, every 5 minutes, 288 readings per day. But what it does is, with the right education and knowledge, it teaches a person how they uniquely respond to food, medications, physical activity, stress. But the key is you needing that little bit of education to understand what the data means, what it all means with those trends. Next slide. So what we developed was actually a shared medical appointment program where the pharmacist was really serving as like the provider in this appointment. And this was done in conjunction with another diabetes educator, which was usually a nurse or dietitian. And then we had 4 to 6 patients, and we offered this multiple times per month. And patients would wear the device for 7 days, and then they would come back. So next slide. So this was actually a 2-appointment model where in the first visit, we provided education. And I found that this was a great way to sneak in education, because when you bring up education, not everyone's like, oh yeah, I want diabetes education. A lot of people will say, oh yeah, I've had diabetes for years. I already know what I need to do. I just need to do it, right? But with the opportunity to wear CGM, they were willing to come in for appointments, and we were able to ask, well, what do you know about your glucose targets? And it turned out a lot of people did not really know what their targets were. And if we're asking someone to monitor their blood sugars and they don't know what their goals are, then how is that data going to be really meaningful? So that was a great aha moment. And after the 7 days, we would bring the people back, download the data, and actually show it on the screen in front of everyone. So we're all here together, the 4 to 6 patients, the 2 clinicians. A lot of times I have a student or a resident with me too, and talk about it together. And lots of aha moments, like learning what specific foods raise blood sugars. And, you know, I could always tell a person, oh, cereal will raise your blood sugar and egg won't. But there's something about seeing it on the big screen or seeing it in real time that really reinforces that and improves outcomes. And in fact, we were able to publish our data and show that on average, each person that went through this did have a 0.8% improvement in their A1C. Next slide. So, you know, we do a lot with CGM, but also I think there's a big opportunity for insulin pumps. And this is an area that's growing for us, certainly with type 1 diabetes. You know, we encourage insulin pump use, especially with all the excitement with automated insulin delivery. But we're also seeing an uptick in use actually for people with type 2 diabetes that are on multiple daily injections. And so this is a real opportunity. Pharmacists can be insulin pump trainers. And one of the advantages I found to doing this was that I can make sure the person has their insulin before starting. And I can also help design those pump settings, those initial settings. So that really helped to facilitate the process. And then for follow-up, I could help to make adjustments by looking at the data. And much of this can be done remotely because now most of these systems, they have mobile apps where it can be connected to the cloud. And so we can follow up a couple days later, look at that data together and make changes. And this was also a reimbursable service. So it worked very, very well to get involved in this. And then next slide. And then virtual visits. So I kind of want to close off with this because virtual care, I think the COVID-19 pandemic really caused an explosion of virtual care. And that was probably one of the most positive aspects of it, that we learned real quickly, oh, we can pivot and we can provide many of the services we were doing in person virtually. And in fact, it's so easy to look at CGM data, pump data, and now we have connected insulin pens and we can look at that data and we can be very efficient and follow up patients closely. And especially with remote monitoring, we can even proactively look at patients' data and reach out to them with concerns. And so I think we are at a really exciting time in terms of all the advancements in diabetes. I think pharmacists are perfectly positioned to be a part of this. I think we can be technology champions. We should be. And I'm just really happy to be part of this program. If you want to go to the next slide. There you've got my contact information. Feel free to find me on social media, reach out to me, but really an honor to speak with you all today. And I'm just so excited where the profession of pharmacy and diabetes is headed.
Well, thank you so much, Diana, for that fantastic presentation on what is essentially a practical guide for setting up pharmacist care for diabetes patients, and especially the use of technology. And I love the idea of pharmacists as technology champions, increasing the, I'd say, the stature and the integral member of the pharmacist in the diabetes care team. So I think we've had just 3 fantastic presentations, practical guides to how to do these, creating these competencies and creating a care team for patients with diabetes. So we're going to now move on to the question and answer part of our program. I will add this note before we start, and I know we have some questions already, but this part of these webinars is always a highlight, at least for me, so that we can hear from you and learn from you. Your participation is really vital in making this webinar even more valuable to all of us. You've got experience, you've got expertise, you've got questions that can be addressed by our speakers or by other attendees on the session. So don't hesitate to ask any questions. Put those in the Q&A box. If you have any other comments, please put those in the chat. So let's look at what questions we may have now. Well, I think the first one's pretty easy for Sally Ann. Where can we get an e-copy of the Diabetes Care book?
Hello, it's available on the Diabetes UK website. So you literally search on there, but I can also provide a copy back to the team here, a link for that, and then they can access that.
Mm-hmm. I'm not sure I know the full impact or the meaning of this next question, but how do you prove diabetes is service connected? I think I'm going to have Diana try to address that one. I think it's more of how you develop that care team with the other health professionals, but it may also be how do you prove the worth, the value of the pharmacist and patient outcomes?
Yeah, that is always like the magic question, because proving your worth on the team. So fortunately, I mean, now we do have a number of publications that I think have really shown and demonstrated pharmacist outcomes, especially like in the United States. We've shown that the more frequent follow-up with the pharmacist versus kind of usual care helps people to get to their goal faster, which can certainly be extrapolated to better outcomes. And we've certainly seen that with A1C. And I think there's some data to show even some harder outcomes, like the reduction in hospitalizations or emergency department visits. So that, that data continues to be really important. I still need to publish this. I'm like kicking myself for not, but soon, in my diabetes center, I compared my services to the usual care with just following with the endocrinologist, showing that patients did get their A1Cs down faster to 3 months versus 6 months, and it was lower. And that's in endocrinology, where you think already we have kind of the highest standard. So definitely in primary care environments, it's like, I think everyone agrees there's so much doctors are being asked to do. They can't possibly do it all. And it used to be where it was more of like a territory battle where, doctors were like, we don't want to share the revenue. But now I actually recently had a conversation with someone from the American Medical Association, and it's actually quite the opposite now, where it's like, we need all hands on deck. There's so many people to take care of. Diabetes is rampant. We need everyone. We need the whole team.
So I know there's some other questions, but I just want to follow up on that last comment. You talked about the diabetes care team. And so tell us, in your world, how many pharmacists are on that team and who are the other health professionals?
Well, it's going to vary a lot based on practice and everything. In my practice, so I'm in a diabetes center. We have 2 pharmacists. We have, I think, 3 dietitians. We have 2 nurses. And we have a number of endocrinologists. We have access to an exercise physiologist, and hopefully soon a social worker. I think it depends a lot on the size. So we, at Cleveland Clinic, we are spread out. There's several locations of primary care. There's main campus, and then there's several outpatient centers. So each outpatient center is kind of a smaller hub. Generally, we place one pharmacist at each of those outpatient centers. And then there's a couple extra like at main campus where it's a little bit bigger. But I think, having one pharmacist working with a few different providers, and then ideally dietitian, nurse, and having access to others can really go a long way. And what's been happening for us is like business is so good. There's so much diabetes to manage that then they start adding additional and they say, okay, can we get a second pharmacist at this location? So
how many diabetes patients do you think you're caring for at the same
so many hundreds, but the thing is, it varies a lot because sometimes I might see a patient, start them on an insulin pump, manage them that first month, and then they're kind of stable and they go back to their endocrinologist. And I'm not, maybe a year from now, they might call me with a question or something, but it's not like ongoing. Versus I also have my regulars where we talk every month. It's probably going to be life. Like, they just need more adjustments and management. So I think it depends a lot. I also, in my post-kidney transplant clinic, it is more acute. It's usually 1 to 2 months after the kidney transplant, and then they kind of go on. So it kind of changes all the time depending who I'm managing. And obviously pregnancy is a defined time limit right through the pregnancy, and then they move on.
Great, thanks. We have a couple more questions in the Q&A box. I really like this next question from Jocelyn. Hi, Jocelyn, how are you? Was there any legislative changes to allow pharmacists to expand their role in diabetes management? I'm thinking of the need for reimbursement for the pharmaceutical services in diabetes. This question I'm going to open up to all three of you because I think it's involved in everything that was said in each one of your talks. So the role of the competency frameworks, FIP, in the advocacy world, the same with the competency statements, frameworks that have been developed in the UK, which I think has been absolutely fabulous. And how is that being used to advocate for the role of pharmacists? And then, of course, we have the boots on the ground with Diana explaining how all that might work. So you got some reimbursement going. So why don't we just go in that order? We'll go Andrea and Sally Ann, and then Diana.
So I think it does depend on the country, and it does depend on the national associations or federations. So I can give you the example of Portugal in terms of helping diabetes management and competency frameworks along with that. So we have developed general competency frameworks for community pharmacists, for example, and that was a specialization that started a few years back. And due to the work that FIP had done in the past, the global competency frameworks and the advanced frameworks were fed into that development from the society into this globally. This is what is acceptable and aspirational. How can we use that in this specific setting? And that led to allowing that specialization on community pharmacists to grow and to be developed, which can lead to diabetes management in a sense. It's one of the things that we do in the pharmacies, monitoring, at least glucose monitoring. So it not as specific probably as Sally Ann and Diane will mention and have clearly and beautifully illustrated for us. But at a global level, what we can use the frameworks is to support and to say, here is the role of the pharmacist. We are able to help and to bring in our added value as a medicines experts. We can contribute to this disease management. And here is all of the evidence, and this is how we can do it and how we can achieve it. So it's really about gathering that whole body of literature and body of evidence to say, here it is, and here is from our setting, from our specificity, an idea to put forward. So I think it does support, it does help going through that change. Not sure how can be implemented legislatively further down the line, but it does really help and support and then have that overview.
If I might interject before Sally Ann
Yes,
comes in.
absolutely.
It supports two other development goals of FIP. I believe one of those is 13, which is policy development. This is critically important. I don't know that pharmacy has paid enough attention to that in the past, but boy, we need to do it now. And the last one is 21, which is sustainability. And this goes to reimbursement for services and all the rest. So really big issues. And for anybody on the call that would like to be involved in this, join FIP and you can dive into these things. So Sally Ann.
And,
wait a minute.
And DG number 5, competency development.
Well, there's that too.
As I cheekily normally say, it's the center of everything.
It's of the universe. Yeah.
So
you're the sun and we all revolve around you, Andrea.
We do, Andrea. It's central to everything. So this is in the UK. We've not had any legislation changes that have sort of led to the change in roles of pharmacists or anything sort of from that perspective. What we have, the only sort of big legislative change that's happening is that pharmacists, undergraduate pharmacists, are going to come out what we would call prescriber ready. So we're now not going to, currently we would do an extra qualification in order to become prescribers. And in the future sort of educational reforms is all pharmacists will come out prescriber ready. And that's going to be really powerful and a really valuable part of supporting the wider healthcare setting in the UK, but also about the recognition of what pharmacists can offer. So that's a big legislative change. From a diabetes perspective, it's not been legislative driven, but it has been about what services have been commissioned. So there've been some great projects in the UK recently where there's been a lot of money put into diabetes, and I'm talking, big money put into diabetes. And what a lot of areas and services did with that was say, well, we've got all the nurses and we've got all the medics and we've got the dietitians. What is our service gap? So there were lots of new commissioned services for diabetes roles. And then the NHS as a whole has looked at where the service need is. And they've invested widely in pharmacy and putting pharmacy clinical roles into general practice, so into primary care practice settings, and commissioning roles that can directly support people living with diabetes and other health conditions as well. I think in the UK, our next big step that we really, really need to move towards is this real empowerment and commissioning of good community pharmacy services to support people early on in diabetes, before that primary care setting, before they ever see me in the hospital setting, to really have value there. So it's not been legislation, it has been about because of our healthcare model, about what's been commissioned, what services are being paid for, and how they're reimbursed on that level rather than the private side of healthcare.
Yeah, so there's been a big push in the United States with like a lot of our big pharmacy organizations for provider status on a national level, and that would really pave the way for pharmacists then to be able to be reimbursed similar to how nurse practitioners, physician assistants are reimbursed in the United States. Currently, there is not provider status at the national level, but many states have introduced provider status. So I'm actually in one of them in Ohio. And the good part about that is then you can get paid from in certain insurance plans. And that is what's starting to happen in states where there is reimbursement with certain insurance plans. Overall, it's still slow. And so that's where we're trying to find kind of more creative ways or partnering with physicians and others for reimbursement. So like some of the codes that I use, like for my remote monitoring or CGM, they still require a billing provider, which is often a physician, but a pharmacist can serve as the service provider. At the end of the day, revenue is coming in. And so you can kind of make agreements with how that revenue is going to be split. But generally, it's good if the pharmacist is contributing to the revenue coming in that way. But yeah, there is still definitely work that needs to be done to further this.
Yeah, yeah. I think the lesson here is we all need to do this in every corner of the world, and every corner of the world has its own particular issues related to this. There's not a one size fits all, other than we need to do it. So appreciate that. And you know, I think in the UK with the National Health Service, you've leapfrogged a lot of other countries in getting pharmacists into these significant provider care roles, which is fantastic. Okay, so now we have a therapy question. At what case or level of case can an obese patient who is non-diabetic take metformin for weight loss, and at what age group? Who wants to take that one?
Well, it's off label, at least in the United States.
Right. Yes.
It is, we do sometimes use it, but it's off label. So it's really up to clinical judgment. And honestly, it's not that effective for weight loss, for weight management. We have many more effective drugs. And now, you know, the GLP-1 receptor agonists, we have 2 that are approved in the US specific for weight loss, liraglutide and semaglutide. So those would definitely be preferable if you're going to use an agent for weight loss in someone without diabetes.
So in the UK, again, we don't have a target weight in which metformin can be used, and it isn't licensed for the weight side of things. What we would put it through on is if a person was what we would define as pre-diabetes, then under a license thing, you could use metformin in that scenario. Practice-wise, we tend not to be going down that route yet. If we are looking at somebody, an obese patient, it is about what other strategies are in place and that holistic care approach, whether it be pharmaceutical or dietitian referral, and wider services for supporting the weight loss. So we wouldn't use metformin in that capacity.
Good. Next question is the pharmacist's role as a diabetic educator. Is this field becoming more an emerging field in the coming years, or are we there already? So,
can I take that?
Pharmacist as a diabetes educator.
I think pharmacists have a phenomenal role as diabetes educators. I think this is a real place that what the community pharmacy is a key part of, with them being the people that have the regular contact with the person living with diabetes. The role as an educator, whether that be structured education or the ad hoc when they meet with the person, I think the pharmacist role as an educator around diabetes is a key part, whether that be lifestyle advice, medication adherence, optimizing for your medication. I think it's a key place where pharmacists can make a easy and valuable and sustainable difference for diabetes care.
I completely agree. And in the US, I mean, it's actually one of the 3 main pathways to being a diabetes educator. Generally, you need to have a license as a nurse, dietitian, or pharmacist. So this has been going on for a while. And I would love to see, though, more pharmacists pursue this path, because I think there's tremendous opportunity, especially in community pharmacies, where, you know, many of these diabetes medications are being dispensed, or now we're seeing a lot of people even getting their technology like CGM through the pharmacy.
Okay. Let's see. We don't have any more questions in the Q&A box, so I'll ask our attendees to keep thinking of your questions and put them in there. We still have another, looks like 5 or 7 minutes to go. I do have a question for Sally Ann, but other people can chime in too. And I think this relates a little bit to what's been asked already, but it's using the competency framework, and I'll go back to the Covey principle of beginning with the end in mind, and let's call the competency framework our end point for this discussion. And how does that feed back into designing programs to get people to be competent? So in the initial curriculum of the pharmacy programs, also in designing CPD programs. And importantly in that, what evaluation processes do you have for individuals to demonstrate their competency? Is this linked to the RPS credentialing system?
That's a great question. And that kind of does fit with lots of the work we've been involved in. So from our competency point of view, we are working with universities to put it in the undergraduate at that level, but we do work with either UKCPA, we have an organisation, Centre for Postgraduate Pharmacy Education, which is a big programme of education provider for pharmacists. We work with those directly to make their learning outcomes to the competency framework outcomes to demonstrate. So they will have designed study days that are put on for pharmacists, and then there are at the end of those study days, there are tests and surveys and feedback and reflections that then show that they're competent in that sector of work. And all of these things, so the study days, the framework, are then all mapped onto our credentialing process, really, to show the evidence of this is the level you're working at. So I've used the framework myself as part of, I'm building my consultant framework portfolio at the moment to work at that level. And I'm using the framework as my evidence that I meet some of these criteria, and I've seen other pharmacists do it in that same way. But we also use the framework as part of our peer review and our peer assessment of each year with our CPD, that's, you know, identifying core parts of the competency framework and then doing peer review and peer discussion and career planning in relation to that. And so there is lots of different ways that are connected, with the end goal really being about that credentialing process and mapping to our RPS portfolios.
So let me follow up on that before we go to, we do have another question in the Q&A box, but in this peer assessment, do you have observation of pharmacists doing the work of diabetes care?
So within our competency framework, we don't, but within our RPS portfolio, we do. So if I will have a direct autopsy, we would call it a direct observation of patient care, where someone would be observing my skills and my competence, and I would then submit that piece for my portfolio submission. So it's all at different points really in the pathway, depending on where we're working and how we use it.
So I'll just make a plug for one of the things that we do in our program, and that's the use of entrustable professional activities. You've probably heard of that mechanism for assessing the actual work of a pharmacist, and at various levels. So I think it's a good framework to use for the evaluation part, I would say. Okay, we have another question, and that is robot RX taking over the role of the pharmacist? Well, let's go to our technology champion who might want to answer that question.
So I don't think so. And, you know, there continues to be more like artificial intelligence and even, you know, algorithms that can, you know, take over or tell us what adjustments to make, or now with pumps, you know, automatically adjust it. But I don't think it's going to take over, because it doesn't replace the conversation with the person with diabetes. And there are just certain things that technology can't figure out. I mean, we're humans, right? So there's an art to it that we have not been able to recreate with technology alone. And so there will definitely continue to be a role, but we have to think more about definitely service, the services we're providing, and not just certainly not just dispensing, right? We really need to think about that service. And I think there's so much we can be doing with counseling on medications and helping people, and even our guidelines really, they're emphasizing that people need the education. So I think that's really where we need to pivot, and we need to focus on that, and then we won't have to worry about robotic anything.
So I think we're going to end the discussion there because we're running out of time. I'll just make one comment on this whole idea of, let's just call it artificial intelligence taking over everybody's job in the entire world. Probably not going to happen anytime soon. But I asked my son about this once, just for the heck of it, and he said, just watch Star Trek, because that's what the future is. Hundreds of years from now. So watch Star Trek and you'll figure it out. Okay, so I just want to thank everybody, our presenters, our audience for their questions. I think this has been an absolutely fantastic webinar with a lot of practical take-home messages for everybody. So again, thank you all so much. It's been a pleasure to be a part of this webinar and to moderate and to listen to all of you. Again, all of the FIP digital events, of which there are, I don't know, hundreds, I think, this year so far, and more to come, can be found on events.fip.org on the FIP website. And there you can view past digital events, including those in the series on diabetes. And you can see which events are also coming up for the next month or two for the remainder of this year. So yeah, encourage you to view this because you'll probably find some other ones on there that you'll have interest in as well. So again, thank you, each of our speakers, for great presentations. And thank you for our audience. And wherever you are in the world, good night. Have a good rest of the day. And for me, I'm going to have a good day, period, because it's still morning. So thank you all again.
Thanks, everyone. Well done, everyone.
Thank you.
Thank you.